Hi, everybody. We are thrilled this morning to have Dr. Andrew Bozoki, who is the director of the UNC Memory and Disorders Clinic at Chapel Hill. And she is going to be talking to us about the latest updates today. And we're just thrilled. Dr. Bozoki, the show is yours.
Thank you. So I'm glad to be back. Those of you who were here for my talk last year may recognize a few of these slides. I have tried to provide information that has come out between last year and now, but some of the things might be a little familiar. I am going to start with a very quick recap of hopefully familiar information, first about Alzheimer's and second about Lewy body disease, which are the two forms of dementia that I'm going to be focusing on today. So just as a quick refresher, not only is Alzheimer's a specific disease or particular cause type of dementia, it is a neurodegenerative disease. That means that it causes the loss of neurons over time. And being neurodegenerative, it is always progressive. The speed of the progression is very variable, as it is for every dementia, highly unpredictable, whether you will be blessed if you're going to have this with a slow course or unfortunately with a more rapid one. Alzheimer's is particularly caused by and associated with abnormally high levels of two particular proteins that are present in neurons. One is called beta amyloid, and the other one is tau. We believe that that misfolding or abnormal accumulation of these two proteins are causal, meaning responsible for the destruction that happens, although no one has definitively proven that there isn't a third underlying upstream cause of both of these two proteins misfolding. Alzheimer's does have a transitional state between normal and dementia, which is termed mild cognitive impairment. Mild cognitive impairment, by the way, is not unique to Alzheimer's disease. Anything that creates dementia can at times have an intermediate stage that people pass through, right? And that would also be termed mild cognitive impairment. It's much more similar, that term, to the word dementia than it is to a specific etiology. And that's why when mild cognitive impairment is accompanied by Alzheimer's biomarkers, meaning beta amyloid and tau, that is when we term it MCI due to AD. Oops, where did it go? Okay, that was annoying. Just flashed right through. I pull up this slide because we also understand that Alzheimer's disease is a very slowly progressive condition with a very long silent period. We now know that Alzheimer's proteins begin to accumulate up to 15 years prior to the development of any outward indicator at all. People can have a brain full of amyloid protein, plaques, floridly positive on a test that would identify them, such as amyloid PET, and yet not have any clinical symptoms at all. And we know of many people who die a long time later with a head full of amyloid protein, never having gotten clinical dementia or even MCI. That's an important concept that I may return to later. The next stage, so there are several stages, and I'm not going to belabor this because a lot of you are quite familiar with this. After beta amyloid comes the tau. After tau begins the symptomatic disease condition, which comes with MRI structural changes, followed by memory, and eventually clinical function is affected. Now that I want to switch slides, now it's not doing it. There. Okay, I want to contrast that with Lewy body disease, which is also a specific neurodegenerative disease that will create overt dementia over time. It too is always progressive, and its speed of progression is quite variable. And I really want to emphasize that we know, in the textbooks, often it says Lewy body disease is more rapidly progressive than Alzheimer's, but in fact, that really, as we have learned more, is not necessarily true. And it can last the same 8 to 12 years, on average, that Alzheimer's does if it is pure. Unlike Alzheimer's, Lewy body disease is caused by or associated with overaccumulation of misfolded alpha-synuclein, and not beta amyloid or tau. And it too has this transitional state of MCI often. One thing that we think is different between AD and DLB is that there is less of a long lead in. That is, there's a closer tie between alpha-synuclein and the development of actual symptoms. People don't tend to be alpha-synuclein positive for 15 years or more, before getting overt symptomatology. The other thing that is different about Lewy body disease is that it can evolve with several different patterns. And we talk about a pattern that starts from below and goes up above. So that is, it starts in the brainstem. In fact, in Parkinson's disease, we think that the first alpha-synuclein containing neurons may actually be in the gut, which has its own enteric plexus of neurons. Believe it or not, they're not called neurons down there, but they are effectively neuronal cells. And the alpha-synuclein migrates from there via the vagus nerve to the brainstem, and then moves upward from that brainstem location to affect other things. Whereas in Lewy body disease proper, rather than starting in the gut, it may actually start in the olfactory bulb. The olfactory bulb is part of the brain cortex. It's way up high. I don't know if you guys can see my pointer or not, but I'm pointing right now to the region of the olfactory bulb. And it can, from there, go one of two different directions. It can either go up into the brain's cortex and cause predominantly cognitive symptoms, or it can go primarily to the limbic system, which is the emotional and psychological and memory components of the brain. And if it's a limbic predominant focus, people may have predominantly and first psychiatric type symptoms from their Lewy body disease. So this kind of variety of different ways in which the disease can start and spread goes a long way toward explaining why Lewy body disease clinically can be so variable. So the now not so terribly new information, but I'm going to give you a little bit of novel stuff along here. But one of the newer advances, and the one that is occupying a lot of conferences, is the new diagnostic techniques that have developed in the last few years. In Alzheimer's disease, the biggest novel form of assessment is blood-based testing. For years, I gave these talks and I talked about spinal fluid testing and amyloid PET image testing, and said, blood testing is around the corner. I started saying that probably about 5 years ago. And now it's actually not just around the corner, it's finally here and in clinical use. Your doctor can order one of these biomarker assays, and they are variable in their quality. Okay, so the tests range in accuracy. Some are a lot better than others, and hopefully the FDA is going to, at some point, not too long from now, crack down and only allow the few that show a, minimum acceptable level of sensitivity and specificity to continue. Know that the ones that are the best are the ones that test for p-tau 217. Okay, so if p-tau 217 is among the proteins that are assessed, automatically it's going to be a better test. The best tests not only get p-tau 217, they also get some other form of p-tau as a comparison or as a denominator, because sometimes p-tau 217 levels can be altered by something like a heart or a kidney problem or certain medications. But in those situations, always other p-tau levels are also affected. So by comparing the amount of 217 to something else, you can get a more accurate understanding of whether the 217 level is truly elevated or not. Know that many of the p-tau tests are just starting to be covered by insurance, and not all insurances are covering, and so it's murky right now. So it's really important to do the pre or prior authorization steps so that you know what your out-of-pocket costs are going to be. Even if the sticker price of a test is $1,200, know that it is highly unlikely, unless you are, quite wealthy, that you, even in the absence of insurance, would be, required to pay the full sticker price. Every single one of these companies, has very generous programs to support their cost for those individuals whose insurance doesn't yet. The other important thing to know about blood-based testing for Alzheimer's disease is that it is not yet accepted as definitive evidence of Alzheimer's in order to receive an anti-amyloid therapy. So those are the two drugs brand named Leqembi and Kisunla. If your doctor is considering you to be a candidate for that, after you've had the blood test, assuming that all of the other things line up for you to be a recipient, they will need to do still either a spinal fluid test or a PET scan. So there are two parallel assessments now in the world of Lewy body disease. Neither one is new in the last year. This is a slide that I presented to you last year. The first of the two ways to identify alpha-synuclein is via the skin. So just like there are nerve cells down in the gut that contain alpha-synuclein, there are also nerve cells in the skin that can contain alpha-synuclein. And when it is abnormal, meaning it's phosphorylated, that's that long word, when it's phosphorylated, and by the way, the P in p-tau also means phosphorylated, then it binds to and stains with a particular kind of identifying stain that is widely used by pathologists and is used in this skin test called an assay. And its technique is the multiplex immunofluorescence, which is that other long word that you see on the slide. Importantly, this test not only identifies alpha-synuclein due to Lewy body disease, it can't distinguish between Lewy body disease and Parkinson's, so it'll give exactly the same information for both conditions. There is a third condition known as multiple systems atrophy, or MSA, which also comes with alpha-synuclein, though not in nerve cells. It comes in glia. And this test may be able to distinguish people with MSA type alpha-synuclein from those with PD or LVD. That's still kind of in the works, and I doubt anyone on this call has a loved one with multiple systems atrophy. Just know that it is yet another form of neurodegenerative dementia. It also comes with some other features. So the practicality of this is a skin punch biopsy done at 3 sites, and your doctor can, if they so choose, order a kit from CND Life Sciences. Somebody will come to their office and train them on how to do the skin biopsy if they don't know how. And this test is covered by Medicare and most commercial insurances. So there is really nothing standing in the way other than kind of time and will for every medical office to be able to do this, particularly if they are like a dermatology group and are used to doing skin biopsies for a variety of conditions. I don't know why I keep clicking on these and okay. So also not new, but now available at UNC this year. We've added the other main way to detect alpha-synuclein currently, and that is through spinal fluid. In those patients that we see, so we're utilizing this primarily in those patients who also need to have spinal fluid testing for Alzheimer's disease. And so rather than doing 2 separate procedures on 2 separate dates, we are using the spinal fluid version of alpha-synuclein testing at the same time, and just sending it to 2 different labs because this one goes to Imprion via Mayo Labs, whereas the Alzheimer's protein tests go to Mayo Clinic directly. This test is like those blood tests, not yet covered by insurance. However, patients often qualify for financial assistance, and in most cases, out-of-pocket cost ranges from $0 to about $250. And this little diagram, well, there are 2 just to explain. The lumbar puncture procedure, which is sort of a scary idea for a lot of people, is something we do hundreds and hundreds of times every year. We routinely train every new neurology resident, as on how to do this because it's a very ordinary and truly unexciting procedure for us. I recognize that the idea of having a needle going into a spot that isn't a vein can be very disconcerting. But we do use lidocaine, which is a local anesthetic that your dentist's office also uses when they fill your, cavities or put on a crown. And the area where we put the needle in is generally a fluid containing space. There's no spinal cord down there. There are a few nerve roots. I really don't think this diagram is the greatest because it makes it look like there's loads of nerve roots in there, but in fact, there are only about 4, and they're tiny. So our track record for getting fluid without any kind of problems is 98%. So the 2%, so 2 in 100 people, typically what they end up with is just a bad headache. So please know that we haven't had any, serious problems in the 5 years that I've been at UNC. By the way, the other diagram, which I won't go into, explains in more detail how this particular assay works. Just know that basically there's a little bit of the person's spinal fluid protein and then a bunch of identifiers or markers. And with each round of adding new identifier, the signal that the machine can detect increases so that what from in the beginning, maybe just a few molecules of abnormal alpha-synuclein becomes a very bright signal over time. So this is new. At this summer's Alzheimer's Association International Conference, which is really for all forms of dementia and not particularly just for Alzheimer's disease, there was a very large and impressive study that was presented and is now published as well by Sonia, I think, Mastenbroek and her group. So what they said, and actually many groups around our country are doing this now too, what they said is that, Lewy body disease is a lot more common than we think. But it's also the case that lots of people will have a little bit of Parkinsonism and or a little bit of cognitive impairment or both for reasons other than Lewy body disease. And doing a spinal fluid test or even a skin biopsy is a lot to do on every single person that comes in with this combination of symptoms. Wouldn't it be nice if we had a cheap and easy, high sensitivity first step that would reduce the number of people that have to go through the more, high intensity, complexity, and expensive tests that I just outlined for Lewy body disease. And so what they relied on is the results of a lot of data from the last few years, including data from the consortium project that my center belongs to, which is that the sense of smell is incredibly commonly abnormal in Lewy body disease. Remember what I showed you a couple slides ago about how in Lewy body disease, often the alpha-synuclein begins first in the olfactory bulb. So what I've learned though is that if I ask somebody if they think they've got a poor sense of smell, literally almost never do I get a yes. I mean, and the few times I do, it's because they've just had COVID. So people don't know, they can't tell that this is an issue. And so a scratch and sniff test was developed some years ago by the University of Pennsylvania. And they, of course, cleverly named their scratch and sniff smell test after themselves. So it's the OPSIT, or University of Pennsylvania Smell Identification Test. These booklets are not super cheap, but they're a lot cheaper than those procedures. And essentially, by having everybody with Parkinsonism and cognitive impairment do that step one, they were able to risk stratify, identify a subgroup, right, that they then went on to do spinal fluid testing on. There's a lot of verbiage here, but here's the important parts. First of all, when they did this two-step process and compared it both to an antemortem, a large group of people who just had were followed clinically over time. That was about 350 people, as well, about 1,200 people, and a smaller group that they also had post-mortem information on, about 350 people. What they found is that they were able to get a 94 overall % accuracy for predicting the post-mortem Lewy body pathology. That's incredibly good. I know it's not 100%, but it's really fantastic. Even more fantastic, a lot of the people that they looked at didn't have a whole lot of Lewy body disease symptoms in life. They mostly were identified in this large group as having predominantly Alzheimer's disease. And they were 94% accurate in predicting Lewy body copathology in this group that had mostly Alzheimer's disease symptoms in life. So this is a spectacular success, this model, and what they found is that by doing the two-step model, not only were they, very high in their identification rate, but they also were able to cut down substantially on the number of people that they did the spinal fluid testing on. Okay. This is a little bit of a segue, and you guys saw this slide last year. I'm bringing it back because I just had a conversation a week or so ago with Pat over lunch, and she emphasized to me how hard it is for people's primary care, local GPs to have any level of understanding or facility with Lewy body disease identification and management. And I told her that I was part of a committee that worked for many months to develop this tool, the US-based Diamond Lewy Management Toolkit, which is basically really a series of pages aimed at primary care, focusing on each of the 5 major domains of dysfunction that occur in Lewy body disease and identifying both do's and don'ts for each of those domains. This is available to you anytime you want at that website URL that I've listed on this page. It isn't, I promise you, that intimidating, I swear, to print out a copy for your own primary care clinician. I know it can feel a little weird and awkward. Hey, doc, I'd like for you to read this. But I would say about 85% of doctors are very open to professional, so not Google, not Dr. Google, that's ugh. But if you provide them with, actual journal publications or this kind of vetted scholarly review information, they're usually quite open to it. Yeah, you may indeed still get some people who are unhappy to receive this information from you, and I don't know, they'll get over it, and maybe some of them will actually also read it. And I think this is, in the absence of more general, broad training right now at this moment in time, this is your next best bet. Okay. All right. So transitioning to a refresher and review and a couple of additional pieces of information about anti-amyloid antibody therapy. So year by year, this was first introduced, this kind of therapy, in 2022 with aducanumab, which was unfortunately not well vetted and poorly launched, and subsequently has been withdrawn from the market. But it has paved the way for 2 other commercially successful treatments called donanemab and lecanemab, which are Kisunla and Leqembi, respectively. These are all man-made antibodies that attach to part of the beta amyloid molecule. And just like if that beta amyloid molecule were an invading viral particle or bacterium, by flagging it with the antibody, it tells the body's immune system that this is bad, it's other, it's an invading alien and not part of its own self. And so then it sends cells in the microglia to chew it up and get rid of it. I'm going to, for anyone who wasn't on this last year, this is just a 2-minute explanation of how these anti-amyloid therapies work. And so hopefully, just tell me, somebody out loud, if you can hear the sound. Well, right now there's no sound.
Some evidence suggests that amyloid.
Can you guys hear that?
Yes.
Somebody?
Yes.
Great.
Removal slows disease progression in Alzheimer's disease. In a phase 2b trial, the monoclonal antibody lecanemab, which binds with soluble amyloid beta protofibrils, was associated with clearance of amyloid in patients with early Alzheimer's disease. In this phase 3 multicenter double-blind randomized placebo-controlled trial, 1,795 adults 50 to 90 years of age with early Alzheimer's disease were assigned to receive intravenous lecanemab at a dose of 10 milligrams per kilogram every 2 weeks, or placebo. The primary efficacy endpoint was the change from baseline in the score on the clinical dementia rating sum of boxes, a validated measure of cognition and function in Alzheimer's disease, assessing 6 domains that patients and caregivers identify as important. At 18 months, mean scores on this measure were higher than baseline, indicating increased impairment in both groups. The mean change in the score was smaller in the lecanemab group, indicating less cognitive and functional decline. Secondary endpoints, including scores on other Alzheimer's disease rating scales, also suggested less disease progression in the lecanemab group. The most common adverse events in the lecanemab group included infusion-related reactions and amyloid-related imaging abnormalities. The authors conclude that in adults with early Alzheimer's disease, lecanemab was associated with less disease progression than placebo over 18 months. Full trial results are available at nejm.org.
Okay. I still feel like I can't do any better than that in terms of explaining. So even though it's proprietary, that video to specifically lecanemab, I keep using it. Okay. Why? No. All right. Okay. I'm just going to move on and ignore the frustrations of my not always working PowerPoint. So I want to highlight that there are 2 main areas of concern with this type of therapy. The first that he mentioned is termed ARIA, short for amyloid-related imaging abnormalities. And it's called that rather than, say, brain edema, because for the most part, this is a finding on a scan, on an image. Okay, it only produces clinical symptoms sometimes. Not even in the majority of cases will people have any symptoms. It's also 2 different kinds of abnormalities. The one that more typically will cause symptoms if it happens in a larger part of the brain is the edema or swelling. The other type of ARIA are microbleeds, teeny tiny, like pinpoint sized, basically leakages from blood vessels. And almost never do people have symptoms from microbleeds. You can have 25 microbleeds in your head, and some people actually do, not from this drug, but because of a condition known as CAA, cerebral amyloid angiopathy. They walk around with lots of microbleeds in their head, and yet they don't have any problems whatsoever. What we worry about is that very, very rarely, instead of a microbleed, right, the blood vessel kind of ruptures rather than just leaking, and then you can have a larger area of bleeding. That is vanishingly rare, except in people who have CAA. So those folks don't get treated with this kind of therapy. And also, we think that it's much riskier to receive a clot-busting drug, right? Something that I'll talk about in a moment that's used primarily in a stroke, large vessel stroke. We think that if you've got weakened blood vessel walls and you get one of those, you may also have a macrohemorrhage. So this is contraindicated for use in well, so I'll go into that in just a minute. Most people, so like I said, they don't get symptoms. The symptoms that happen when you get symptoms from ARIA, the most common one is headache, which is actually kind of a problem because loads of people, as we've learned in the last couple of years of using this medication, loads of people will get headaches for a whole slew of different reasons. And some people just get headaches when they get any kind of IV. So it can be difficult to distinguish headache from ARIA from headache from the infusion. One thing we know is that people don't get ARIA right during their infusion. It takes days and days afterward to start having ARIA. And so anybody who gets a headache while they're getting the infusion, or within an hour or two thereafter, we've learned to just treat with Tylenol. We don't panic anymore and send all of those folks to the emergency room. Okay. So that takes me to the second type of side effect that people can get. This is actually more common than symptomatic ARIA, and it's called an infusion reaction. An infusion reaction is a little bit like an allergic reaction. It's not quite the same physiologically in the body. And an infusion reaction doesn't mean if you get it once that you're going to keep getting it. And it also doesn't mean that we need to stop using the medicine the way we would if it were a real allergy. What it means is that we need to pre-treat you for a while with like Benadryl and Tylenol so you don't get this essentially what looks like the flu transiently for an hour or two during or after an infusion. People can actually get infusion reactions from just getting salt water. So it's something to do with the IV-ness rather than just the specific drug that you're getting. And you can see kind of some of the symptoms. The dizzy, lightheaded, blood pressure can drop. You can feel a lot of like rapid heart rate sometimes, and or a fever and flu-like symptoms. Okay. So the two things that we focus on in terms of evaluating your risk when you're going to receive this kind of therapy, the first is and they're both focused on whether you're at high risk of getting symptomatic ARIA, basically. And as a general rule, most people are not. What we've learned is if you carry 2 copies of the E4 variant of the apolipoprotein E gene. I know, a long sentence. If you have 2 copies of this particular flavor of the gene, then you are at higher risk. And with 2 copies, we do not, at our center, treat you. There are other centers around the country that have decided that that increase in risk is still acceptable as long as, patient and family understand the risk and they will treat anyway, just so you are aware. We also don't treat if you have a lot of pre-existing microbleeds because we think that signifies that you already have this problem of the weakening in the blood vessel walls that could trigger a larger hemorrhage if we go ahead. I'm going to highlight that the benefit is a slowing, as was shown in the little animated graphics. The slowing in disease progression is greatest when you are at the earliest stages. So, and we've really seen that play out in our own clinical experience with our own patient population. As a rule, the people who do well, meaning that their disease seems to overtly slow in its progression, are the people who have MCI. Although the drug is approved for use in both MCI and mild AD, the more progressed you are in your dementia, even at the mild dementia stage, the less likely that you're going to have an observable, sort of noticeable change in the disease trajectory. So that is why I am really I'm going out to areas of the state of North Carolina that have, larger populations of older individuals and also have sufficient primary care base that they could change their methods in their clinics for identifying people so that they get identified at the MCI stage rather than at the mild dementia stage. And that's an ongoing project for me. I'm working at the moment with Boyce Willis Clinic in Rocky Mount, as well as the Pinehurst Medical Group in Pinehurst. Okay, this is probably not news to anybody anymore. These are given intravenously. The infusions take about an hour. Lecanemab is every 2 weeks. Donanemab is every month. And in between the infusions, both require periodic MRI scans. So, you're going to a medical center pretty frequently when you're on one of these therapies. And still, although this is improving, there are still not a huge number of participating infusion centers. There are starting to be a lot more. And, Raleigh Neurology recently has onboarded their own infusion program for the anti-amyloid therapies. So access in Raleigh has expanded considerably, alongside us and Duke. Okay. A few little questions that I get asked a lot that I put on this slide. The first is a dilemma around how long to treat. Okay, know that the two companies that manufacture respectively lecanemab and donanemab have come to completely opposite decisions and conclusions. And that tells us, the doctors, that the real answer is nobody has any clue. I'm not going to bore you with their rationales, but just know that lecanemab, which is manufactured by Eisai, says you need to be treated forever, and they have developed a new injectable subcutaneous version that they're recommending as a weekly maintenance therapy after you achieve clearance of beta amyloid from the brain from 18 months of IV use. Donanemab says once you're clear, you're clear. Maybe not forever, but certainly for the next few years. And so if the doctor, demonstrate that the person is cleared of beta amyloid via an amyloid PET at 18 months, then they don't recommend anything more than an annual follow-up beta amyloid scan. And there is not yet clear-cut recommendations for retreatment, but presumably if after a few years you're starting to creep up, then presumably we would retreat for a period of time. So the doctor also needs to stop if and when a patient is no longer at the mild stage of dementia, because there's no role for this treatment later. Okay. The second question I get asked a lot is what happens to people who develop ARIA, meaning an imaging, an MRI abnormality, okay? Not necessarily with any physical clinical symptoms. So know that if you get ARIA on one of the scans that we do for safety, then we pause infusion, okay? People with ARIA, the ARIA goes away when you stop the medication. People who have symptoms from their ARIA get better when you stop the medication and the brain swelling resolves. There is nobody with just ARIA who has not gotten better and have all of their symptoms go away. The only people who have any kind of long-lasting or, permanent effect from their ARIA are those in whom the ARIA is accompanied by something else, like a stroke or a major bleed. And, that is a rather low likelihood, but not zero, not impossible. Okay, finally, this is what I alluded to a few slides ago. What is my risk of brain bleeding if I need a clot-busting drug for a stroke? That's the TPA that has been given for probably 25 years now, or 20 at least, for strokes. And the answer is we don't really know how big the increase in bleeding risk is. Theoretically, it is increased, right? And at this time, the recommendation is that if you're actively receiving one of these anti-amyloid therapies, that you not get the clot-busting drug in the case of a stroke. So that is a real downside consequence to think about before you get started with this therapy. It's something we now, counsel patients on, and know that some large clots to large, larger blood vessels, that kind of stroke, sometimes we can mechanically remove the large clot with a receiver device in the catheterization lab. That does not involve the use of the TPA medication and would be considered fairly safe to use in certain forms of stroke, but by no means are all strokes or even most strokes amenable to that kind of mechanical retrieval. So please be aware that around the country, emergency rooms and stroke doctors are grappling with this. Okay. So the last section that I'm planning to present here before we break for questions is the clinical trials landscape. Okay, and there's going to be, forgive me, there are a lot of words here. You can read the words or you can listen to me, and this whole talk, of course, will go up online later, so you're welcome to go back and read the words or study the images at a later point if you wish. Okay. So every year for the last 6 or 7 years, a neurology expert by the name of Phil Cummings has created a graphic of this kind, which seems to just, of course, get busier and busier, which isn't meant for anyone to actually scrutinize carefully. What it's meant to do is give you a gestalt, an overall impression of where is the research world headed in Alzheimer's disease. So the different colors on this circle represent drugs with different purposes. The orange slice are symptom treating medicines that improve cognitive function without slowing disease progress. The green slice are those things that are given by vein and are meant to slow down the disease. So they're biological agents like antibodies. The largest section, which is purple, are also approaching the disease in some manner, not just treating symptoms, but somehow treating the underlying physiology. Whether they do or don't slow disease progression is variable in this big purple slice, but all of these are oral. They're pills. And then the the blue slice, this is new. These are just starting to be developed now. They're called neuroprotective drugs, meaning that somehow they, instead of slowing disease, they protect against. So sort of like a vaccine. And you can see in the bullet points on the side some of the characteristics of the current pipeline, and importantly, as our biomarkers get better and easier to perform, more and more of these research studies are incorporating biomarkers into them. However, the time it takes for one of these drugs to go from the center of the circle, from the outside of the circle, which is a phase 1 first in man study, all the way to the middle, where it is the final step, phase 3, before the FDA reviews and approves, is still taking 7 to 8 years. And if you add to that how long it takes for the preclinical development, from somebody saying, hey, I wonder if this compound does anything, all the way to when the drug can get presented for review to the FDA, it's 11 to 13 years. Okay. So What's in the inner parts of the circle for Alzheimer's disease, the things that are looking the most promising and immediate. The first focus is really on improving over Kisunla and Leqembi. Okay, so those are first generation anti-amyloid therapies. They have their limitations. One of those limitations is the frequency of ARIA, and the significantly greater risk to people who are E4, right, which really excludes them from being treated. So a newer form of anti-amyloid therapy, which is about to be, the phase 3 is about to start, is looking very promising at reducing the amount of ARIA significantly to, just on MRI under 5%. It's also very rapid, much more rapid in its clearance than either of those first generation treatments, so that it takes 6 months rather than 18 months to get to clearance in most people. So stay tuned. Phase 3 is starting. It actually is like the first sites have already opened. The other area of active in later stage push is for an anti-tau antibody, and I think this is going to be a critical development for addressing everybody who's at the mild dementia stage and beyond, where it's pretty clear that the anti-amyloid therapies are not going to work well. So anti-tau antibodies, because tau is at a later point in the disease, it's more closely tied to the progression of dementia. By interfering with the spread of tau, there's a lot more optimism about whether you can actually slow later stage disease. There are 3 different drugs, 2 of which are in phase 2. Neither one has announced their results yet. The Johnson & Johnson product may be announcing its results at next summer's AAIC. So the other 2 are a little bit further behind. The ASI study is the ASI product is the newest on the block. Okay. At UNC, I'm just going to put in a quick plug for this, although I think we unfortunately have more than enough patients just from our clinic as it stands, but we're about to launch a new clinical trial for early Alzheimer's disease that uses a different kind of antibody instead of antibodies against either beta amyloid or tau. This is one of the projects that is looking at neuroprotection at later stage, so in active disease, by solving the microglia problem. So if you remember, microglia are the ones that are supposed to go in and clear out all of the beta amyloid protein and actually the toxic tau aggregates as well. And the microglia in Alzheimer's disease just can't keep up. There's too much. And so the idea here is that by improving the microglial protection factor, it should reduce neuroinflammation and reduce the amount of cells that are affected as the disease progresses. So it's a different approach, one that makes a lot of sense molecularly and biologically, and potentially may work across multiple disease states, although they're obviously going for Alzheimer's right now. The recruitment is going to be a total of 420 folks, but MCI and mild AD were one of the sites, and it's a long study. So anybody who does this is going to need to commit for at least a year and a half. And the drug is given every 4 weeks with periodic MRI scans for safety monitoring. So it is a lot of visits to one of the UNC centers. The infusion center we're using is Easttown, if you know where that is. This is a dose ranging study, meaning that some people will get a low dose, some people a high dose, some people placebo, but overall, the chance of getting an active dose is over 2/3. And because no one knows yet whether ApoE status, gene status, has any bearing on this drug. In the beginning, in the first 100 or so participants, they're not allowing E4, E4s, but assuming that the safety signal is not worrisome out of that first group, they're going to likely open it up to E4, E4s as well. Just letting you know. Okay, switching my focus to DLB. I think that for those of you who have somebody with Lewy body disease, Pat has probably kept you very up to date on the outcomes of the recently completed research studies. We were involved in 2 of the 3. This one, the very unpronounceable neflamapimod, was completed at this point almost a year ago now. This was a drug to reduce brain inflammation, and its phase 2 trial was called Rewind. Several of your family members may have been involved at our site, I don't know. And the study ended up initially being negative. It turned out that the reason it was negative, we think, is that the company used outdated capsules for a lot of the study. Ooh, what a mess. And, those were not biologically as active. In their extension study, where they replaced the outdated capsules with fresh new ones, they did show a significant signal similar to what they saw in their phase 2A. And so they are approved to go forward on that data to the phase 3, which is going to be starting probably in another 6 to 9 months. The second drug, which we also participated in the clinical trial of this one in Lewy body disease, works in a manner somewhat similar to an anti-amyloid therapy, in that it helps to displace or remove the protein aggregates. And this one seems to work well against both beta amyloid aggregates and alpha-synuclein aggregates. So full disclosure, I am a consultant for this company. So know that anything I say is potentially biased. But the phase 2 results are public record and, do show that there was significant benefit, meaning compared to placebo, there was better preservation of behavioral, cognitive, and motor assessments in Lewy body disease. And the company already has a phase 3 going in Alzheimer's disease. Finally, nilotinib. This is a repurposed cancer drug and seems to enhance protein clearance generically. Also may be effective in multiple disease states, and is currently a phase 3 is being planned for both Parkinson's and Lewy body disease on the basis of their successful phase 2 trial, although they're working on the details of how to conduct their next study. It's not close to opening yet. Just a very quick mention here, I'm not going to belabor that. Know that just like in Alzheimer's disease, that what I'm highlighting, which are to me the most exciting studies, because they focus on disease progression and, modification, But there are other avenues that are being explored, symptom treatments and non-drug treatments in the form of something called transcranial magnetic stimulation. TMS has been approved by the FDA for years now as a way to treat depression. And it is looking particularly promising for, just so you know, for treating apathy in Lewy body disease. The active research study in Parkinson's is happening at UNC. And with any luck, if it shows benefit, the next stage will involve Lewy body disease participants as well. And we're also one of the sites that will be participating in a treatment study targeting hallucinations and delusions that you can see mentioned here. The drug name is ACP-204, and we're about to open that study to enrollment in the next few weeks, really. Okay. A quick plug for where to go. If you're interested in volunteering for a clinical trial, this is your best starting point. Trial Match, and I mentioned this last year, serves as a clearinghouse, and it's a more user-friendly way to find a study compared to the clinicaltrials.gov, which is where this site is pulling its information from. But it can kind of help make it a little easier to use. Please go ahead and look. I am going to stop and open it up for questions. Know that, let me stop sharing for a minute. There we go. Know that I have